Okay, thank you so much for that opening. That was a great opening, great start to the day. We're going to move right into session one. I'd like to invite Dr. Mark Moon, my co-moderator, up to the panel. The first session is on aortic valve replacement, and we have none other than Joe Wu, Vice President of the AATS, to give us the state-of-the-art lecture on how to choose the best valve substitute. Thank you, Joe.
Okay, thank you, Moral. And those are two very tough acts to follow. Thank you very much. Okay, so my title that I was assigned is Choosing the Best Aortic Valve Substitute, Mechanical, Tissue, Ross, Why, and How. So we'll try to go over some of those things. I have no disclosures. I think we've all talked about how Tirone is a technical phenom. And when you do a PubMed search on him, you can see he's quite the scholar. There's 444 publications there. There's probably many more that we're not counting because they forgot the E after TE. But anyway, what I thought is maybe we could spend a moment or two just talking about how he's also a wonderful human being. So Tirone, in his younger day, I don't know if this is what you look like when you came, but I found a younger picture of you. You came to visit us at the University of Pennsylvania 20 years ago. And that was the first time I got to meet you, although I was reading a lot about you and we were doing your operation, albeit maybe not as well as you were doing it. And, you know, I have amazing mentors at Penn. You know, Joe Bavaria is in the room, and Joe Bavaria taught us a lot. And so I was asked to, as an assistant professor, present some cases to you, some information, both clinical and basic science. So I presented a valve repair case, and I'll show you that in a second. You liked that a lot, and you really congratulated me. And then I presented my science work, endothelial progenitor stem cell work, at which point you looked at me and said, "Young man, you are an alchemist." So, you know, an alchemist is someone that takes base metals and tries to convert them into precious metals. And so I think you were sort of making fun of the research a little bit. I'm not sure you were giving me encouragement on that. Well, nevertheless, 20 years later, the stem cell work still is not going that well. But this is actually, I think, the patient I showed you. So this was one of my very first valve-sparing aortic root replacements done 20 years ago. He was 59. He had a 6-centimeter ascending aortic aneurysm, 4+ AR, and his EF was 45%. And I did a valve-sparing aortic root replacement and a hemiarch. That's his 1-year CTA with very nice-looking sinuses. And this was done with annular plication and sinotubular junctional plication. And I actually went and tracked down this patient. And I asked him for permission to go and get his follow-up echoes. So he's 79 years old now. He's alive and healthy. He just got cleared for cataract surgery. And this is his echo from a year and a half ago. And he has trivial AI and a mean gradient of 8. And his EF is normal now. So Tirone, your operation works, even in inexperienced hands, if it's just done correctly. And so we learned so much from you about this operation and other operations. Fast forward a few years, and this is the American Heart Association meeting where Viv Rao and I are hosting dinner, and I had the privilege of sitting next to you and chatting with you. And this photo is very interesting, not about anything about you, but you sat next to me and you said, you know, Viv's our boss now, but take a look at that young woman down at the end there, okay? And I'd never met Moral before, and you said, that is the future. That is a superstar in the making, and you're gonna watch amazing things from her. That's what you said 12 years ago, and I listened, and look what's happened. Yeah, you're a genius. So. Okay, a couple years after that, we were in Japan, and my wife, Amy, had a chance to meet you. And again, such a gracious human being, Tirone. You spent a lot of time talking with her. We had some meals together, And during those meals, you never talked about surgery. You talked about what her work was about. You talked about your children. You talked about all sorts of other things. And she really enjoyed spending time with you and has since then as well. What's really funny about this particular meeting was she was also photographed with the two of you, Magdi Yakub, and I don't think at the time she understood what it meant to be in that particular photograph. Because I've shown this photograph to so many younger surgeons, and every one of them said, I would kill to be in that photograph. So, there she is. And then more recently, a few years ago, you came to our house and you honored Larry Cohn and you honored Roberta Cohn. And you were so gracious to our younger faculty and all of our residents. Again, just a perfect example of what a wonderful human being you are. Okay, let's move on to the topic. So I was asked to give a talk on state of the art. Well, we always go to the guidelines, right? And so I'm not going to show anything from the guidelines because the European guidelines, being led by Michael Borger, is going to be updated, and that'll come out later this year. And so we'll have really state of the art later this year. And then the ACC AHA guidelines are being updated and hopefully will come out late 2026, maybe early 2027. And we're very hopeful that there will be significant AATS and STS contributions to these guidelines. So let's talk about the data that we have, okay? So these are some topics that we could talk about in AVR. Aortic valve replacement versus aortic valve repair. I think we've settled that debate. So clearly aortic valve repair. What about TAVR versus SAVR? Well, we're not going to have that debate here. I think many people would say they'd want a SAVR. Aortic root enlargement versus Bentall. We're going to have that discussion. I'm a big fan of Bentall. I don't do aortic root enlargements too much. So we'll have that debate later. So really, we'll try to focus a little bit on mechanical versus bio. And there's a lot of topics here. We can talk about bileaflet mechanical valves. We can talk about stented versus stentless versus Ozaki versus xenograft versus homograft versus Ross pulmonary autograft. Obviously, we don't have enough time to go over all this, but we'll touch a little bit upon those things. But we'll mostly focus on mechanical versus bio. Okay, let's go to the data. All right, let's start with something out of Mount Sinai. So published in JAMA, pretty good journal. So what did this show? Well, basically, no difference in survival, no difference in stroke, and the big difference is, of course, reoperation for biovalves, bleeding for mechanical valves. Okay, that is in the 50 to 69-year range. We worked on this that was the entire state of New York. This is the entire state of California. And what do we see here? Well, the question really is, in the aortic position, when is the benefit of a mechanical valve lost? And so the confidence interval crosses at 53. Okay, so what about the Cleveland Clinic? So something a little more recent. So they looked at their entire experience, and really, what did they say? Was there a difference? And really the message here, no difference, but mostly because reoperative surgery for bioprosthetic valve degeneration was very safe. That was an important point that Dr. Adams made this morning at the mitral valve replacement session. If the reop is done safely and correctly, then the advantage of a mechanical valve sort of disappears. That's really the difference. The difference in the Mount Sinai paper and the difference in our paper was really due not so much to the mechanical valve being better, but that the reoperative rates of mortality, the mortality rates for reoperative surgery in both the aortic and mitral position were really high. And the mitral position was 13.3% in the state of California over a 20-year period. So that will affect the results. Okay, so what about something much more recent? Okay, this just came out. Several people in the audience are co-authors on this. 100,000 patients, STS database. And it's happening again. Confidence intervals cross basically for unadjusted around 57, 56, and for risk-adjusted, maybe a little bit older. So again, in that same sort of range, somewhere in that mid-50s, the advantage of a mechanical valve disappears. Okay, so summary statement really is more reoperation for biologic valves and more bleeding for mechanical valves, right? But that's not really the whole story, because this is not necessarily the comparison. The comparison that we're studying might actually be this. It might be older generation valves. You know, certainly if you're looking back 20 years or so, or 30 years, that's what you're really looking at, not necessarily the modern day devices. And those studies also do not really account for this. What is the impact of this? Okay, so remember, data are good, but data do not encompass everything. Okay, so just a couple other things. Mechanical valves. Has anyone seen this? Yes, of course. We see problems with mechanical valves. One leaflet not moving. When you reoperate on these patients, you see lots of pannus. When you reoperate on mechanical valves, you can see this sort of thing also. So mechanical valves are not necessarily one and done. Well, are there better mechanical valves? Maybe. So I think we've all moved to bileaflet valves. There are valves that have structural designs that have a bit of a funnel inflow into the valve, maybe for better hemodynamics, potentially for better anticoagulation benefits. There's always the talk of warfarin home monitoring, and then there's the sort of the xenotransplantation equivalent, that is, oral anticoagulation for people. Maybe that's the future, and maybe it will always be the future. We don't know. But there's also this possibility, right? So if the mechanical valve doesn't work, well, why not just fracture it and then put a valve inside of a mechanical valve? So this was kind of interesting. If you read the bottom, it says that they were able to capture a lot of the fragments in a filter system. They saw 2 fragments floating in the left ventricle. They couldn't find them. And then they didn't detect any problems, so that was fine. And then at 4 months follow-up, they found some fragments in the iliac vessels, still causing no symptoms. So, TAVR valve in mechanical valve is coming. Or it's here, let's say that. Okay, what about some newer designs on the bioprosthetic, or newer opportunities on the bioprosthetic end? So Inspirus has an annulus that can be expanded. And if you want state-of-the-art, this is just presented by a group. I think 2 of the authors are here. 2 of the first 3 authors are here today. This was presented at Heart Valve Symposium, basically showing a comparison against Magna with a potentially statistically significant benefit, less reoperation due to structural valve disease, Inspirus versus Magna. So very interesting. So fresh off the presses, or not yet to press. And so this is a summary. I put this in here. I wrote this about a decade ago. I want to read this because I think it sums it all up. While abundant published variables may be integrated into valve choice decision-making, several additional contemporary factors include patients engaging in much more active lifestyles, enhanced safety of reoperative cardiac surgery, and the potential for transcatheter valve-in-valve solutions for bioprosthetic structural valve deterioration, balanced to some degree with home testing of the anticoagulation state, the potential of novel oral anticoagulants, and the progressively increasing mean life expectancy. One might also consider biomaterial fixation techniques that purport prolonged tissue durability and mechanical valve design features that purport lower anticoagulation requirements, while also remembering that specific prostheses have experienced early or unanticipated failure. What is certain is that technology and techniques will continue to evolve and advance. Finally, Dr. Miller said this, for the majority of patients, all of the data and future prospects regarding valve choice will be conveyed through the interpretive filter of the experiences, preferences, and opinions, however unbiased, of the patients, physicians, and surgeon. I think that sums it up. Okay, let's just briefly touch upon some other options. So there are stentless bioprosthetic valves, whether they're rapid deployment or sutured in. There are pericardial replacements. This was presented at the AATS, and I was the invited discussant. This is my comment. We credit Professor Ozaki with his creativity and his reported outstanding long-term outcomes. However, widespread adoption of the operation has been challenged by variable reproducibility of the operation and variable reproducibility of the outcomes. Additionally, in aortic valve repair operations, there is published evidence that pericardial replacement of portions of the aortic valve, often respectfully referred to as partial Ozaki procedures, yields worse long-term outcomes. So that's a personal opinion, but I think that's shared by many people. How about stentless xenografts? Well, they have issues too. We used a lot of these, and there are issues with ostial coronary stenosis, pseudoaneurysm, and leaflet abnormalities. And then homografts. They serve wonderful purposes in filling the aortic root for endocarditis and abscess, but are they ideal as an aortic valve replacement substitute? Probably not. This is, I'm using this paper not to highlight how awesome Ross is, but potentially how not as ideal and how long-term degeneration is an issue for homografts. And then finally, the Ross. So first the why and then how. So Dr. Lauer and Shumway described this in dogs. This was published in our journal in 1960, and then in the late 60s done in humans by Donald Ross. So Morale and colleagues published this, really just showing the benefits of the Ross compared to bioprosthetics. And then I think probably the most important paper that we all refer to is Ishmael's paper, basically showing that the Ross is not only better than bioprosthetic or mechanical, but over long term actually puts you onto the actuarial survival curve. So as good as going back onto the general population survival curve. So the two bottom lines over there. So I think that's very convincing. But what are the Achilles heels? Well, one is autograft dilatation over time. So we've done several of these operations, and we would do the Tirone David operation after a Ross failure. And so we were asked to write an editorial on this. So Andrew Goldstone and I wrote this, and we thought it was a cute name. Should a David repair a Ross? And we think that often if the cusps are fine, you can go ahead and do this. And we're seeing several of these patients. We saw these at Penn, and we're seeing these at Stanford. You know, patients with basically normal cusp, but some annular dilatation and essentially pulmonary arterial dilatation over time. So that's an Achilles heel. And so we said, well, if we can do a David to fix a Ross afterwards, as many people have done, we've learned from Jibrin El-Khoury and from Vaughn Starnes, why not essentially do the David up front? Do it in advance. So jacketing the pulmonary autograft might prevent the late dilatation. It should. And, you know, these valves look very nice once you implant them. This is one of the patients I did, and, you know, that looks beautiful in there, and you know you're not going to get annular dilatation because the annulus is inside that graft, so that's your external stabilizing ring built in, and then your sinotubular junctional extension graft or your interposition graft is all built in here too. So it's an efficient way to do this. But of course, Tirone has a comment. You know, Tirone is such an expert in everything, and of course he has an opinion on everything. I'm not going to tell you how he feels about this. He'll, I'm sure, say something, but anyway, we should wrap or we should not wrap. But one of the issues there can become efficiency. So here's the how, okay? So we have, this is a traditional sequence where, you know, you have to do a lot of left-sided stuff, then right-sided stuff, and then you go sort of back and forth, back and forth. This can add up to a decent amount of cross-clamp and bypass time. And there are a lot of published results showing, you know, 3-4 hour cross-clamp times. I don't want to show those. I do have the sort of familial permission to poke fun at Joe Bavaria. And so I'll show something from Penn. And this is the restart of the Ross program there, recently published. And look at that. Bypass times of 300, cross-clamp times of, over 4 hours. That's a lot of time. So what can we do to make this more efficient? So beating heart, autograft, might help, autograft harvest. So this is how we are harvesting our autografts. So instead of starting on the left side, we start on the right side. And this basically shows us taking out the autograft. And a lot of the steps look very familiar, coming through with a right angle. And most of this can be done just with beating heart. And once you're familiar with how to do this on the arrested heart, it's actually not that hard. And we're actually using the same principles. On the back, we turn the scissors just like, Jabreen and Tirone and Ishmael and Vaughn say all the time. Flatten your scissors in the back and make sure you're avoiding the septal perforator that way. We're doing all the same things. It's just the heart's moving. Okay, so how does that change things? Well, that allows you to do all that autograft preparation, not cross-clamp. So this is an example, 73 minutes cross-clamp time. And then that will now allow you to do cases that you might not consider because of that long cross-clamp time. So how about severe LV dysfunction? Would you do a Ross here? So, that's an ugly-looking valve, so we did a Ross. And short cross-clamp time, the heart works fine. What about age and other comorbidities? Here's a 65-year-old that came all the way from Hawaii for Ross. We cathed him, he had LAD disease, so we had to add a lima on top. Would you do a Ross there? Well, short cross-clamp time, it's not an issue. How about trying to minimize or reduce the bypass time? So we resequenced the Ross operation. So what does that mean? Okay, so now what we do is we thaw the homograft first, prepare the homograft, get it all ready to go, beating heart autograft harvest, and then while it's still beating, we go ahead and sew in the homograft. So that's doable. We haven't done anything on the left side yet. So finish off the autograft, that's homograft, then come off bypass. So de-air the right heart, come off bypass. Now you're completely off bypass, and all of this is free time now. So all of the autograft jacketing is free. And then the rest of it is just like a regular Ross operation. You can test it, you can readjust things, etc. And then you just do the left-sided operation. I won't show this. Okay, so the first 10 patients that we did, they did great. Median cross-clamp time, 72 minutes. 69 to 80 is the range. And remember, STS isolated AVR cross-clamp time is 78 minutes. Our median CPB time is 142, range 129 to 162. Patients did great. So what about a best use case scenario? So you can't order this stuff up, except Morale somehow ordered this up. Basically, 2 weeks ago, a 44-year-old came. I scheduled her for a reoperation after an aortic valve repair done when she was much younger at another hospital. And when we opened up, she had a bicuspid pulmonic valve. So we did this as a beating heart approach and resequenced. So nothing's done on the left side yet. And there she has fusion of her left-facing and right-facing cusps. Small fusion, but is that something to abandon? What can you do? Well, if you do it with this sequenced approach, you can spend all the time on the back table, not on bypass, not cross-clamped, readjusting things, getting the commissural heights perfect inside the graft, basically doing a David operation on a bicuspid pulmonic valve on the back table for free. And that's it after it's been mounted into the aortic position, and it works great. So she did great. And last comment here about clinical things is I've been listening to Ishmael, right, saying the sinuses. It's all about the sinuses and the normal aortic function, right? It's a living aortic valve. So make more room. So we've been putting it inside a Valsalva graft to buy it more room for more sinus function. We'll see if that works well, but you can see that look. That's a nice look after Ross. And then very last comment is we've been testing these out in the biomechanical engineering laboratory. That's our system. Dr. Tirone David, when he visited, went down into the lab and even did his valve-sparing root replacement operation, which we tested, and found that you did the operation correctly. It actually works. So when we test out Ross's inside of the jacket, a lot of the leaflet hemodynamics and kinematics are actually still preserved. So we just submitted an NIHR1 this week on looking at different graft configurations to see what is the ideal jacketing approach. So in summary, maybe mechanical valves less than 60, bios for pretty much everyone else. TAVR explant is the fastest growing operation in the United States. There are all sorts of other approaches. Ross's, I think everyone would agree, people in their 50s, I'm sorry, in their 40s. I'm definitely doing them in their 50s. We're doing them in the 60s. I think others have talked about doing them in the 70s. Beating heart autograft explant shortens cross-clamp time, resequencing, doing everything on the right, everything on the jacket, and then everything on the left shortens CPV time further. And then jacketing preserves leaflet biomechanical kinematics. So back to the alchemist, Tirone. We all think of you as someone magical in the operating room. You know, someone who has, golden hands when operating. But I would say that I think you have a golden heart and that everything you touch turns to gold. Thank you.
Thanks, Joe. I had the pleasure